and the entire NBE team, because I understand what you said, and entirely agree with that. It sounds a kind of a casual way to, okay, this is only one part of the table viva, but to make it really go in your own way and to guide the discussion, you need to prepare yourself. You have gone through this in your MBBS, you have gone through this in your MS surgery or DNB surgery as well. And the same thing will be there in DNB surgical oncology also. Only the level of discussion, the way to discuss the things, and what are the points of discussion, that is going to be slightly different. And how you guide that, how you control that, that is a matter which of definitely will require some preparation, as well as a kind of a template formation also. That's true for any practical exam, that you want to rehearse yourself how to do that. If I get this, what I'm going to do there. If I get that, what I'm going to do there. What I'm going to say, and what are the points I'm going to include in that. So just like the the part of the instruments, there is a section for surgical specimen also. So to organize my talk, what I have done is that first give you the value as well as the requirements and expectations from a candidate who is appearing for DNB surgical oncology final exit exam, and what the examiner's point of view is as per their thought, what they want to see in candidate. Apart from that, the also what are the things you should know on the sideline of the core surgical specimen part. It's not that the whole discussion will be concentrated only on the specimen side, what it is that's done. No, it's going to be something on left and right also. For example, they can ask you, do you think in this specimen the margin is all right? So essentially that becomes a kind of a starting point for discussion. So first part is concentrated on what are the things you are expected to know, as well as what they are expecting from you. And the second part will be the individual representative specimen pictures will be there. And I'll tell you that roughly what are the points you should be preparing yourself not to miss that, and also how to describe that. So, like I said, the practical examination of DNB surgical oncology is divided in two parts. One is the theory part, one other is the practical part. Theory part is over. Now, since practicals are coming, so practically again divided into two major parts. One is the group of cases you will be getting. So, there you are tested for approach to management, how to assess a case, how to evaluate a case, and then how to go about the management preparation or management planning. Then comes the second part of the practical examination, that is the table viva part. And this is divided into four parts again. And each will be carrying 25% weightage in themselves. So important thing is that they are not interlinked. It's not like that if you did badly in radiology, that is going to carry it over to operative procedure description or surgical instrument, or for that matter, if you did very well in surgical instrument, that impression will be carried to surgical pathology either. It's not like that. So they are independent sections and you have to take them on their own. So prepare accordingly. And the four contents which are there, first is radiology, then operative procedure description, and third is instruments, which we have already discussed previously, and the last is the surgical pathology specimen. So why surgical specimens have been kept at the first place? It could have been just like some video also, some pictures also, but yes, there is a reason behind that. And the examiner's team wants to assess your basic anatomy. First of all, whether you are able to identify the organ itself or not. Yes, I can understand that sometimes there may be confusion, but that is the basic you expected from a candidate, that you can identify the organ as well as or the part of the organ, and then identifying the pathology in the organ. What is abnormal? Why that surgical intervention has been done? So that brings you to the possible indication for surgery. If you can know the pathology, then you are expected to comment also that what kind of possible pathology is there. Do you think this is a benign one? Do you think it's a malignant one? Accordingly, the nature of surgery will be also there. Not in terms of indication for surgery, that is established already. Then comes what kind of surgery could have been done, whether this was for benign nature of pathology or for malignant, because these two are going to vary. So that will determine whether the surgery was adequate or appropriate or not for that kind of pathology. Essentially, that kind of a, practically speaking, that becomes a pretext to start further discussion. That okay, you have identified the organ, you have identified the pathology and possible operative procedure. Things don't end there, because there is a almost 10 to 15 minutes kind of discussion for this section, so you can't finish that in 10 minutes. So essentially that it starts a discussion related to the pathology you have described, related to the organ you have described, and the oncological aspects of that particular operative procedure. That's what I said, that just naming the organ, naming the pathology, and naming the procedure, that doesn't bring the end to the whole exercise. So you have to have a knowledge of pathology affecting the organ. At the same time, you should also be able to comment based on the visible pathology, the staging classification. So you have to have a basic staging classification information. Then they will ask you that, what do you think? What kind of pathology and what kind of stage is this? So you should be ready for that. So it's not about just the very pointed discussion, but there is a broad discussion starting from your identification of the organ and then pathology. So let me come to the fundamental question, that when you go there, what do you expect there? Practically speaking, because of the pattern of the examination which we have been following for years and years traditionally, this is one of the section which I always get complaint from the candidates also. Sir, I don't think that was a very good looking specimen or representative specimen. Yes, that may be true. Reason is that most of these specimens are years old, brought from museum. They are kept in a glass container containing some liquid. They will be hanging in some liquid. That's what you will be seeing that. And if the host examiners are not very considerate, they may throw you just like some totally discolored or shrunken kind of specimen. So it may sometimes become difficult to identify whether this is a cut section of liver or this is a cut section of lung, because both are shrunken and solid kind of thing. So yes, there are ways to identify that, but if they are very old and very discolored or maybe to the extent of disintegrated, you may have trouble. And most of the time we will be asked just to see that, see from all around, and not to touch it at all. So what you are going to do, you know that three things are going to be there, what I mentioned earlier. So most important is that you should have some practice beforehand. Try to go and see the uh, museum specimen, which are most of the time, maybe number is limited or so, but some specimens will be there in your hospital wherever you are there. If not, you can ask your friend to arrange a visit to some academic center or the medical college, where most of these specimens definitely are kept there, because they have to teach other trainees like MD and MBBS also. But never carry the impression of a freshly resected specimen. That's what I wanted to make you aware about, because you may find some good preserved specimen. That's what we try to keep that, but it's not guaranteed that you will get every time something which is looking very familiar to you, which you have carried the impression during your surgery. Either you have attended that as an assistant, or you have done yourself. Then comes the question that once you have it in front of you, how do you describe it? So most important, just like your for case viva also, you prepare a template that these are the points I'm not going to miss. So make a checklist that this is the kind of checklist or template I'm going to have. Take your time, because generally they will ask you, okay, choose one. So have a look. If there are 4 or 5 of them, you can just give a scanning all around and figure it out which one you are comfortable. If you are given a choice, why don't you use it to your advantage? So yes, take your time in choosing the specimen if you are given a choice. Then take a good look from all sides. It's not like that you have biased your mind or fixed up your mind. Oh, I have just seen it. This is what, that's it, done. No. Take a good look and figure it out if there is something wrong, what is there. Many times it will be cut open or it may be cut section also. Sometimes it is just a slice of liver, slice of lung, or a cut section of uterus. Or I mean, most of the time you have a representative whole organ, but many a times you just have a section, and be prepared for that. What they desire is that a clear and coherent description. It should not be haphazard or it should not be jumping here and there. So prepare accordingly and how you are going to describe. Simply, this is organ, this is such and such organ, this is a, such and such pathology. So I'll come to that later on, but there has to be a way of description, and they expect you kind of a one-line statement to start with. If you are confident in that, the rest of the discussion becomes very easy, I can tell you. So they don't want to hear that this is a specimen of gastric cancer. No. Here you have an organ in front of you, which may be cut section or which may be cut open, or it may be the whole organ. So don't say that this is a specimen of gastric carcinoma, or for that matter, this is a tumor of lung metastasis. No. First of all, this is lung. First of all, this is stomach. Say that. And then include what is included in the specimen. Like if you are saying gastric cancer, then definitely there are going to be a attached omentum also. There may be part of some other structure, like if you are going for example, ovarian cancer, then there will be staging specimen of ovarian, total hysterectomy, bilateral oophorectomy, along with that broad ligament will be there, along with that omentectomy will be there. So like that, you have to keep a mark that what is included in the specimen. Omentum will be included with hemicolectomy specimen also, and omentum will be included in the gastric cancer specimen also. But both have to be spoken about. Then comes the any visible pathology or abnormal area which you can see. For that region, I said that take a good look. Don't be in rush, don't be in haste, so that you don't miss that. So there may be a growth. There, what kind of growth is there, where it is located, and just describe briefly the growth. There may be ulcer, just like suppose you are getting a specimen of oral cancer, hemimandibulectomy specimen, there will be ulcer, there may be a growth also. Or there may be a nodule. For example, if you are getting a liver tumor also, or the lung mass, so there may be a nodule if they are given in the cut section or cut open. Then the anatomical location and the nature of pathology. You are expected to include that as well in your description, that where it is located. It is located on the surface. Is it located in the fundus, in the gall of the gallbladder, whatever it is. But you have to make it a point that you describe the location also. And then comes the important thing. What do you think? This is a benign pathology or this is malignant pathology? Again, if you're too much in hurry, you can just say that, sir, this is adenocarcinoma of stomach. No, that's wrong. Here you are expected that up to what extent you can describe the pathology in terms of its nature, benign versus malignant. That much is good enough. Let the examiner take over if they want to probe you further. Rather than committing yourself, this is a squamous cell carcinoma of esophagus. This is a adenocarcinoma of uterus. No, don't do that. So if it's a malignant pathology, say it like that. Then becomes what could have been the possible surgical procedure. You have to name that, and then possible extent. Is it a simple cholecystectomy or is it a radical cholecystectomy? If you are seeing the liver segment attached to that, then you know that this is a radical cholecystectomy or extended cholecystectomy, not a simple cholecystectomy. So that much is expected, and these are the basic points you have to prepare yourself once you prepare a template for any kind of organ description. Like I said, surgical pathology and histopathology, they are not synonymous. I pointed here, you can see, if you say, sir, this is a seminoma of testis, again, the person will be offended. I'm not sure whether this is a seminoma or non-seminomatous tumor. All I know is that this is a testicular tumor, which may be lymphoma also. That has to be analyzed further. So surgical pathology is different. And histopathology should not be muddled up. So don't bring histopathology in that unless you are asked about what could be the possibility. Then you should avoid using histological variant terms. Squamous cell carcinoma, basal cell carcinoma, clear cell carcinoma. No, don't do that. As far as organ pathology is clear and organ pathology described, that should be good enough and that should be left over to the examiner. And you should describe only what you see. Don't get biased just because you may have seen the specimen previously or your friend told you that okay, there is a specimen like this which looks like this. No, what you see, make your opinion and go independently by that. And always wait for examiners counter questions. Don't be in hurry. There are plenty of questions going to be there. If you try to kind of jump the gun, probably it's not going to be in your favor. Then there are common counter questions. How did you identify that? You have to then come up with some telltale features of that organ. If there are calluses, it's going to be kidney. If there are rugosity, if there it's going to be again either stomach, it may be possible also in sigmoid colon. But then there are going to be tinea, so it will be differentiating whether this is stomach or this is going to be colon specimen. Then there are some characteristic structures which are present. If it's going to be a testicular tumor, in all probability, you are going to have a hanging spermatic cord attached to that. So you know that this is a solid globular organ which is attached with a cord-like structure. In all probability, it's going to be a testicular tumor or testicular specimen. Then counter question will be there, why it is stomach, why not rectum? Like I said, they have to tell them the telltale features of that particular organ, that this is the shape, this is both, because both are luminal structures, but there are characteristics to differentiate between stomach and rectum. It may sound fairly very basic at MBBS level, but please do expect these questions simply because the specimens will look, after being preserved in for years and years, that you may get confused that everything is looking luminal only, whether this is stomach or the rectum. I have seen people getting confused about that, and it's genuine. It's not nothing to be laughed about. It's genuine just because the specimen will be looking like that because of discoloration, because of change in various conditions of the specimen. And important is that you have to orient it correctly. Although there will be kept in correct orientation most of the time, but you have to check it that whether this is kept in correct orientation or not. If not so, then you have to point it out. I can keep the jar upside down also. Probably the specimen is fixed with the jar, it's not going to fall. But that is just to confuse you. Don't get confused and make sure that you come up with correct orientation. Then some other counter questions will be there, that what is the possible surgical procedure in this one, for which this specimen has been taken out, and what is the extent of resection. Do you think this is a simple cholecystectomy? Do you think this is a extended cholecystectomy? Do you think this is a segmental colectomy or this is a proper right hemicolectomy? Because appendix will be attached to that. In segmental you might not have, so you have to give answer according to that. Then what is the abnormal lesion? You have to identify that, and what is nature. Unless you have included that in your description, they will be definitely asking that what is the nature of the lesion. So like you said, there is a growth looking. What kind of growth? Is it a malignant growth? Is it a benign growth? And if that is so, what is the possible diagnosis for which this surgery has been done? And then comes the question that do you think that this procedure is appropriate or adequate for this pathology? Then you have to comment about that. That extent of surgery is adequate or not. If there is no omentum attached and you are saying this is a gastric cancer specimen, then yes, I expect omentum to be attached in that, and that should be commented about. Then comes the question that what do you think, the margins are adequate or not? Because they want to know that how you are you aware how much margin is required for this kind of pathology and for this procedure. So they will ask you a broad question, can you comment on margins? then you have to answer whether they are adequate or not. Yes, it's a shrunken specimen, but grossly it should be normal. That is something expected from you. And then comes the question about if there is any alternative treatment for the described pathology. Because after all, the very purpose of going through this section is not to just to assess that whether you can identify a culprit or not. No. But what is the implication of that? What are the knowledge base which is required to deal with particular kind of pathology? Because once you come through, suppose you are operating a case and you come through an incidental finding, you have to make up your mind there, what kind of pathology is this and what should I do about that? That's what is being tested there, that if you see some pathology, can you identify that? And if you can identify that, can you manage that? Then comes the tricky part. What if you are completely blank? Yes, there are certain situations where the specimen is so old and to the extent of almost disintegrating that it becomes very tricky to comment about what specimen is this. You can argue that why this is not uterus. If I say that no, this is urinary bladder specimen, yes, you may have point about that. There are certain features which are there, but on the spot and just like a spot identification, it may be sometimes become tricky. And there then you have to accept that I am not sure, but to me it looks like. That's how you can describe that. Generally, they are generous and they will ask you, okay, no problem, you can pick up another one if you are, if they agree with you that yes, this is a confusing specimen. So you'll be given a chance about that. That much you can expect, and generally examiners are that much liberal and considerate. But the rider is that you should not be sounding so confident on a wrong point that you are trying to just to sell your diagnosis and trying to fool the examiners. No, sir, you cannot do that. If you try to do that, you will pay a heavy penalty, because your tone, your description, that will convey that you are exactly trying to fool the examiner and you are not exactly applying your brain or accepting your limitation that you cannot identify that. If you try to describe it in a very confident manner, a wrong thing, that goes against you, and I won't advise to do that. So simply be humble and accept that, like I said, that you are not sure, but that your guess is that. If you say that much, that point is going in favor of you. So let's come to the now how to handle a surgical specimen, because these are certain points you will be asked to describe out. What are the ways to preserve it? So most common way is to go for formalin fixation, because it has certain advantage, like it's cheaper, easily available, and it can be prepared easily inside the operation theater also. But at the same time, it had disadvantage also. Number one, it totally discolors the specimen. Also, what happens is that the texture, the color, the consistency, everything is altered to the extent that slowly it starts disintegrating, because it has its own shelf life. And because of the formation of the formic acid, it's not an advantageous solution for preserving the calcified structures like bone, because slowly with time formalin, the formaldehyde, that gets converted into formic acid, and then it leads to further disintegration of the specimen. Now, what are the alternative solutions for specimen preservations? You should be having an idea as well, like 40% isopropyl alcohol, 70% isopropyl alcohol. There are certain other things as well which are not commonly used, but they can be used for that. And then comes that what if you are going for frozen section, how you are going to handle the specimen. Never say that I'm going to put it in formalin. No, because frozen section specimens, they are just collected on the spot, fresh specimen, and they are frozen and processed according to the requirement of H&E staining without putting them in formalin. So that you have to be clear about how to handle a frozen section specimen and how to handle a permanent specimen, and what is FF, what is called formalin fixed paraffin embedded specimen. That's the correct way to express that for permanent fixation. So what formalin does to the specimen? First and foremost, you must have noticed that all these specimens, they are shrunk. They will look shrunken simply because there is a shrinkage to the tune of 10 to 60%. If you go for esophagus, then shrinkage is up to the tune of 50% or so. So that brings the margin very close to where the tumor is there. So you may comment that because it's a fixed specimen with the formalin, the actual margin might have been bigger, but it is shrunken, so this much is there. So that knowledge is expected from you. Like I said, this apart from the changes in color, it also changes the consistency. It becomes very hard. The texture becomes very, what was glistening and very smooth looking, it becomes very rough and hard kind of surface. Also, there is effect on nucleic acid. You may be asked that, okay, there is a formalin fixed specimen in front of you. Can you go for RNA extraction from this specimen? Yes, you can go for that, but the yield is very limited. Compared to that, the DNA yield is relatively much better, but RNA very poor because it breaks the covalent bonds which are existing between the nucleotides. So that leads to essentially disintegration of the nucleic acid. So that's not a good idea for if you want to analyze the sample on molecular basis or DNA analysis or RNA analysis for a long preserved formalin sample. So what are the difficulties you will be expecting when you go for the description of that? First and foremost, like I said, that this is going to be an old specimen and shrunken, so it may confuse you. It may also be wrongly oriented. Be aware about that. And if the specimen is very old and examiners are not very particular about that or considerate, they may give you a disintegrated. So pieces are falling on the floor of the jar. You can see that it's a muddy kind of a specimen. So that's a disintegrated specimen. And sometimes it's difficult to identify and you have to accept that. And examiners will be giving a leverage for that. Don't worry about that. With this background, now I'll come to just representative what specimens you are expected or you will be getting that. This is going to be a pattern description. This is not going to be a comprehensive list of 1 to A to Z or something like that. But this is the way or this is the pattern you will be expecting, and you can expand your list. But the point of description, point of discussion, point of question will more or less remain in the same nature. Let me come to the most common one. Almost every exam will have this specimen. Just you can see here, this is a modified radical mastectomy specimen. So they will ask you first to describe that, because you can identify that with the presence of nipple areola. There is an axillary tail. So this becomes not a simple mastectomy specimen, but a kind of modified radical mastectomy specimen. They will also ask you, if you say modified radical, why this is not a radical mastectomy? Since you can't see here attached the muscle, so you can safely say that it looks like modified radical mastectomy specimen. And if you can, if the specimen is cut open many a times, or if it is visible from the surface, you can describe like here, there is a tumor. You can see here, there is a protruding kind of tumor, which is almost infiltrating the skin. So some skin changes are there, and this is a quantitative modified radical mastectomy. So once you have described that, then the discussion starts that, okay, what are the kinds of other types of modified radical mastectomy you are aware about? What is the margin? How do you preserve the thoracodorsal pedicle? And some anatomical aspect of the axilla you should be aware about, that where the nerve to serratus anterior is located, what is the significance of intercostal brachial nerve, where are the nodes of the internal mammary chain located. So these are some sample questions you will be asked about, and you should be prepared for that. So if some skin changes are there, you can be asked to point out that what are the skin changes. If there is a destruction of nipple areola, you should not be missing that. Here there is a puckering, you can say. The skin is pulled inwards at the point of invasion. You can say clearly and include that in your description. The Viva will go according to your answers to the extent what all you can answer. Then it can go up to right up to treatment or management, or also to some extent the operative steps, like how do you raise the flap, what are the points to keep in mind when you are raising the flap for a modified radical mastectomy. So what are the other kind of total mastectomy you are aware about? What is the nipple sparing mastectomy? How do you reconstruct the areola or nipple once you have reconstructed the breast also? So these are the side questions you should be aware about. But this discussion starts with the specimen and it can go anywhere according to your answers. Another one is here I like to bring your attention. There is a growth, protruding, also proliferative growth in a specimen of hemimandibulectomy, or I should say arch preserving. Segmental mandibulectomy is this one. Here is the hemimandibulectomy, because here you do not see the condyle here, and in this one the classic what you describe as hemimandibulectomy is appearing there, and you can see also a growth which is infiltrating the surrounding margins. You have to comment about what type of hemimandibulectomy has been done. You should be aware about whether this is classic hemimandibulectomy or arch preserving or segmental mandibulectomy. So you have to be aware about these variants of the procedure, what could have been the indication, and then do you think the margin is accurate or not here, margin is adequate or not here. What are the complications of this surgery? What are the structures you should be, how do you preserve marginal mandibular nerve? These are the some questions you will be always expected to answer. Similarly, which one is the coronoid process, which one is the condylar process, what is the definition of infratemporal fossa, what are the boundaries of infratemporal fossa. So these are the side questions you should be always aware about, particularly also about the procedure. Then they will ask you that how do, once you have taken out this specimen, what kind of defect do you expect and how do you reconstruct that. So these are some of the questions you will be expected. You have identified that, you have described the procedure, you have described the indication, then the viva moves on. Third most common in the head and neck will be thyroid specimen, which you should be able to identify because its shape is like that. Bilobar, two lobes are there and attached with the isthmus. And then many a times what they do is to keep it upside down. So the isthmus will be there on the upper side rather than the lower side. So you should be aware about what is the location of the isthmus and what is the correct orientation of the thyroid, which is the anterior part, which is the posterior part, because on posterior part you are likely to have impression of trachea also, and the posterior part is more flattened rather than convex. And then also if there is a nodule, like you can see here, if it's a cut open or if it's a gross nodule, like in the cut open section, you can see here there is a nodule which is clearly easily identifiable. If that is so, what kind of nodule? Probably it's going to be a malignant nodule. What is the probability of malignant nodule? Then you can say that if it's a multifocal, it looks more like a papillary carcinoma. If it's a single nodule, it may also be follicular neoplasm, follicular carcinoma. So that's how the viva will progress. And once you have described that, then they will be expected to answer certain questions about what are the complications of this surgery, what will happen if you suddenly the superior thyroid artery is bleeding or it has retracted, how we are going to catch that, how we are going to control that. Similarly, what is the location of the parathyroid in this specimen, and what is meaning of total thyroidectomy, what is meaning of near total thyroidectomy, what is meaning of hemithyroidectomy. These are some of the points. I am not going to describe this, but I'm just trying to make you aware about what are the things you are expected to know or answer when you get specimen for thyroid. You are expected to identify and describe the pathology, yes, but beyond that, there are certain things you should be aware about. You may get confused here. If I give you only this part, then you'll get confused whether you are dealing with liver or you are dealing with lung. But yes, this is, I mean, you cannot make a mistake here. This is a lung specimen. There are clearly, it's a better preserved specimen, and many times you have just a shrunken, some black looking specimen, and unless you have a hilar structure where you can identify the bronchus or the artery or so, then sometimes it becomes difficult. And you can see a pathology clearly here. A tumor is there, and where is the tumor located? This is a lobectomy specimen or pneumonectomy specimen that you have to identify. This is a lobectomy specimen. And also, not only that, where are the fissures? What kind of pathology is this? This is a malignant looking pathology. So what is the nature of the surgical treatment? So along with that, what do you do, like mediastinal lymph node resection? So these are some of the things you should be aware about. What are the structures included in that, and how do you orient that? So is it a right-sided lung or is it a left-sided lung? If it's a pneumonectomy specimen, you will be asked about, and you are expected to know about all these things. Similarly, what kind of tumor do you expect? This is a small cell tumor, non-small cell tumor, in all probability non-small cell tumor, because for small cell tumor at the first place, you will not be going for surgery in all probability. That's the reason I kept this specimen immediately after the previous one. Just to recap that, let me go back. So if I give you only this part, you may get confused with this part, right? It seems like if some fissure is there, but there is no hilar structure in this one. And clearly, this may be confusing. Many times you get confused since there is no hilar structure. So you may say that looks like a liver specimen. Actually not, because here you can see the honeycomb or the typical the lung appearance, which will not be there in a liver specimen unless you are dealing with some nutmeg kind of liver. Here this is a complete one. This is the cut open, so you can easily identify that. But the problem is when these structures are not identified, the hilar part is not identifiable, and all you get is only a small part of the lobe. Still, you have to identify the consistency, or for that matter, appearance of the texture, whether it looks like liver or it looks like lung. It's a more spongy kind of structure, less solid, and that goes in favor of, because clearly you can see a fissure also, and there that goes in favor of lung. So if that is so, then what are these nodules? Obviously, they are multiple. In all probability, they are going to be multiple metastasis. Similar in this one also. The next one, this is the better looking preserved specimen, almost fresh one, and here this is the formerly looking, formally fixed. So you can see the difference between these two, although they are not the same one, but yes, the color change is going to be the same. Here you can see a contracted specimen. You can expect that this is just not the total esophagectomy, although this is in all probability, because formally leads to shrinkage of the specimen, so it looks small. You have a growth here, you have a tumor, in all probability a malignant tumor, and the question will be what kind of procedure is so in all probability this is either a McKeown's esophagectomy, it may also be Ivor-Lewis esophagectomy. So that's the way you answer. So don't commit for one thing, because you can see here the G junction area, also the typical rugosity of the stomach. What is the extent of gastric resection you do in esophagectomy? Why do you do that? And what is the anatomical basis for that? All these questions will be there, and you should be ready to answer that. What is the extent of lymphadenectomy you do for this location tumor? You will be again expected to know about that. What is if you are answering correctly, then they may also go to neoadjuvant and adjuvant treatment also. Apart from that, what are the complications of this surgery, like recurrent laryngeal damage, and then certain other because major structures are there, all these complications you are expected to know about. This brings to the next specimen, and this is a liver cut section. Here you are seeing only part of the liver because either it's a bisegmentectomy or it's a hepatectomy kind of liver. So that you have to see from different side. That's what I told, that many a times in the jar you will see just a section or just a part of the liver which is cut from two sides. This is much easily identifiable. This is a difficult one. This also you can identify based on the appearance and the nature of the texture as well as the shape of the organ. So here you can say that this is a solid looking tumor, and in all probability the surgery has been done for, because it's a single tumor, so probability is for hepatocellular carcinoma. So that is good enough. Then you'll see something cut open or something not cut open, just a part of the lumen will be visible and some growth will be there. So this is a cut open part of the stomach. Although this is only one view, the problem is that I can show only with the picture. So the omental part which is there behind that, I don't have that picture, but you will find that omentum will be attached with that. This is a malignant growth from stomach, arising from a stomach, and since you don't see here, or then you have to see clearly that if there is any pylorus or not in this area, then you will come to know that what kind of gastric resection has been there. Most of the time pylorus will be included in that. It only differs that whether this is a total gastrectomy specimen or distal radical gastrectomy specimen, depending that the proximal and distal, the lumen diameter, if that is remarkably different, then you know that this is probably a distal radical or subtotal gastrectomy specimen. Then you have to describe the growth and then the further questions about the procedure. Now that brings to the gallbladder. Here the difference between these two you can clearly see. So this is a polypoidal kind of growth, frond like, appearing in the fundus part of a luminal structure, and the lumen you can see cut open part which is looking just like surface of gallbladder, because bowel will have a totally different, and stomach will have totally different, the rectum will have totally different. This is a pear shaped tubular luminal structure with a fundus. Then easily you can see and tell that this is a gallbladder specimen. This may be a malignant one, and here since the specimen has not been cut open and there is a attached segment of liver, part of the liver, and that you can say that this is a radical cholecystectomy specimen or extended cholecystectomy specimen. So that's how you have to describe that. And there will be counter questions about what is the nature of the surgery, what are the complications of surgery, how do you select your patients, what is the staging of gallbladder. So these are some of the questions you should be ready to answer about that. So then there is a tubular structure with some fat around that. Purposely I'm showing you a formalin fixed one, but this is what will be appearing and this is what will be kept as well. So you have a typical mucosal fold like structure inside the lumen, but uniform diameter tubular structure with a growth here you can see looks malignant. In all probability this is going to be a colectomy specimen. If you flip on this side you will find tinea as well. That's how we will differentiate from other luminal structures. Like I said, that if you are totally at loss that what kind of structure is this, then you have to start from the basic, whether this is a solid or luminal structure. If it's a luminal structure, is it a uniform luminal or is it like a gallbladder kind of lumen? So if it's a uniform luminal, then whether this is a small bowel or this is a large bowel, for that tinea is going to help you. Similarly, lumen diameter is also going to help you, plus the serological surface, that will also be helping you. If you are shown only the cut open part, then you can see there are a lot of fatty tissue behind that. In all probability, it may be either sigmoid or some part of large bowel is there. Since there is no attached appendix or so, you can safely say I'm not sure whether this is from right hemicolectomy or not. All you can say is here segmental colectomy specimen. That should be suffice. Then comes another specimen of rectum or specimen of colectomy with clearly seen anal region or anal canal. If that is so, then you have to, here I have kept the surface of the serosal surface, where you can see the tinea clearly running over the surface. And that is also including the anal canal. So you can safely say that this is a APR specimen. And the viva proceeds that where is the tumor, what kind of surgery has been done, what is the exact nature of the surgery, total mesorectal excision with autonomic nerve preservation, what are the complications, what are the structures which you remove, and what are the additional uh, uh, um, precautions when you do this surgery, how to preserve the autonomic nerve. So that's how you proceed. You will also have sometimes a large tumor with some small area of a normal structure which is looking like kidney. Here, majority part is normal, so easily you can identify that this is yes, this is kidney. Here also you can identify that is the kidney and there is a clearly tumor. Now, this is not having any perinephric fat. Here you can see a lot of fat. So how these two are different? Probably this is a radical nephrectomy specimen. This may be a simple nephrectomy. Here also some fat is there. In all probability, this is a radical nephrectomy specimen and there is a large tumor. Probably it has been done for renal cell carcinoma. If you say this much, that is good enough. What is the location of the tumor? Yes, it's one of the poles. Whether this is including the hilum? Answer is no. Can you go for partial nephrectomy in this specimen? Probably again answer will be no for all the three, given by the size as well as location of the. So these are some of the questions you should be ready for. Another jar just like will be appearing there. It has been cut open just to be seen from outside, and then again you may get confused sometimes that what I am dealing with. But here you have a clue that there is some globular kind of structure which is located at the lower side, and you may also have some penile structures also attached with that. But if not so, then yes, in all probability, this is some luminal structure with very thick wall and nothing but two possibilities. One is that hystrectomy, other is urinary bladder specimen. Since there is a prostate attached here, so in all probability, this is a urinary bladder tumor. The tumor you can see clearly. If why it is not hystrectomy, because then there is a typical wall thickness. Also, the attached broad ligament, and you may also have attached ovaries along with that. Plus, the cervix looks like cervix, not like prostate. For this reason, I kept the next slide as this one. So here you have almost no lumen, but thick walled, walls are very thick, and again a triangular conical kind of structure with multiple outpouching like growth which is attached on the surface. There you can say that it looks like fibroid because lumen is not having much any growth per se. What is the depth, what is the size, etc., etc., and there is a ovary also attached with that. So this is the reason why you'll be, it's not like that they want to corner you, they want to blind you, but yes, there are certain clues there you are also expected not to miss them either. So this is a more like a benign pathology and you have to describe it like that. Then comes the malignant pathology. There you can see there is a growth inside the lumen, and then you have to essentially comment about what is the depth of the invasion, where is the location, whether the cervix is involved or not. In this you can see the cervical involvement is there. So this is more like an endocervical tumor, and many a times because there are other surrounding structures which are attached with that. Here you have a uterus, along with that you have rectum, and you also have bladder. So that clearly makes a specimen of pelvic exenteration. Where is the pathology? pathology that you have to locate and then tell that why this surgery has been done, what are the indications of exenteration. This is one of the favorites of examiners, that you have some different kind of structures kept in a ball-like structure. So you have hairs, you have teeth, you have different germline structure, and clearly you can say that in all probability this is a teratoma. So this is one of the favorites. You'll find that this is a surrounding wall like a tumor like structure. Inside that different structures are there. Again, this is the one sometimes again confusing, but then you have to identify that with the shape, partial penectomy specimen. There is a growth. Again, where is this growth extending up to? If it's a cut section, then whether the urethra is involved or not, what is the depth of invasion and what is the extent of invasion, you have to say. Is it a partial one? Is it a total penectomy? Again, you have to comment about. Sometimes you will find just a tumor kept like that. And if that is so, the first suspicion will be going towards ovary. That is something because that's a structure which has where the tumor completely replaces that. Once you have that, then probably the normal structure is very difficult unless you are seeing that along with uterus and contralateral ovary. If this is only a tumor, then there may be any possibility. You can start guessing yourself, and if there is no surrounding normal structure, you can safely put your guess for probability of an ovarian tumor, because that is the only situation where you will find only tumor, not surrounding structure. If you say that, sir, this is like looking like a gist or so, gastrointestinal stroma tumor, again you should be having a surrounding normal structure also, so which is not there. So, or any sort of omental cyst or so, that may be possibility. But if it's a solid looking just a tumor, the suspicion goes towards ovarian tumor, and the discussion goes further for that. What kind of staging system is there? What is the typical surgery for ovarian tumor? What is the staging, laparotomy, etc., etc.? These are the some of the questions you should be ready to answer that. You can see here the part of the fimbria and fallopian tube. But if you are having a good fresh looking specimen or identifiable, then only that will be identifiable. Otherwise, if you say that my guess is ovarian tumor, that should be safe enough, and they will be giving you grace marks for your guess as well. Then comes the high inguinal orchiectomy. Why is said high inguinal orchiectomy? Because clearly you can see the length of the cord, which is clearly visible, and length of the cord, if this much is there, in all probability this is going to be a testicular tumor. You can see here testicular tumor also, but the length of the cord is comparatively limited. Here you can see clearly the tumor as well as the entire cut section. Then you'll be asked that for what is the possibility for this pathology. Then testicular tumor is one thing. Again, you should say, if you start with, sir, this is seminoma, then you are in trouble. Don't say that. It may be either non-seminomatous germ cell tumor, it may be either lymphoma also, we are not sure about, but these are the possibility, and that should be kept like that. So apart from that, sometimes you will also get amputation, which is easy to identify because it looks like that, and nothing particular is going to be there about that unless there is a lesion like sarcoma or so. So you have to describe, and the questions will be about that. This is you are expected to get, and you should be prepared for. And what kind of tumor is this, where this is located, whether this coming, where the joint is included, involved or not. You can easily see here, this is from the knee joint area, and this is the part of the lower femur coming from, and the tumor is originating from the lower end. What are the possibilities? You should be clearly whether osteosarcoma or chondrosarcoma. So all these things they should be always aware about. This goes in favor of osteosarcoma, and this also goes in favor of osteo, but it may also be like Ewing's or any other tumor. Or why it is not chondrosarcoma, but then you'll have to answer that these are not the common sites, etc., etc. So this is what, whether the marrow is involved or not, whether the periosteum or how much surrounding structures are involved, joint is involved or not. What do you think is the mark margin adequate or not? How much is the margin required for that? How do you reconstruct? So all these questions will be asked, and you should be able to answer that. If it's a bone tumor, if you that much, then you can put your differentials based on the location of the tumors in the knee area. So I like to just finish that with a typical description. This is just a representative. You can make it better also. I just tried to put it for you. And this is how it goes, that this is a surgical specimen of the distal part of the stomach with pylorus and the attached omentum. The mucosal surface has an ulceroproliferative growth which appears to be malignant, probably a surgical specimen of distal radical gastrectomy operation. The counter question will be that why do you say that this is stomach and not transverse colon? Then your answers would be there are rigosti, there is a pylorus on the other end, and the serosal surface or the outer surface is smooth. It's not having any tinea. So I said that this is a um, gastric specimen having a gastric tumor, probably a gastric cancer. If this much is there, then at least your initial job is done, and then the viva proceeds from there. Thank you very much. Now, if there are any questions or in the chat box, then I like to let me first shift to the. I'll stop sharing now, and then. Okay.
Sunil, fantastic talk. Amazing collection of slides and specimen you have. Superb. It must have taken a lifetime to collect it. It's hats off to you. I just know the effort. It's unbelievable. Beautiful. It takes decades to do this. Hats off to you. Superb. I'm so happy I called you and then you accepted it. Fantastic. After such a comprehensive talk covering approach, description, specimen photos, I really doubt anybody has any doubt, and students should really be very confident.
Let us see if there are questions
Yeah,
also. So I think I'll have to stop sharing that. Okay.
yeah,
Yeah.
yeah.
Let me go to the
Students, you
chat.
have any doubts, put it in chat box.
The basic idea is that you should understand that what is expected from you and how do you describe that in a coherent and comprehensive manner so that all the points are included, and describe it confidently, describe it in a way that the person who is in front of you is aware that you have knowledge about the pathology as well as the identity of that pathology.
So there is a question, sir, like when there is a specimen in front of us, will there be ASCII or we just start describing? For your benefit, I'll tell you that you know that we are a panel of experts and council member for surgical oncology. I am one of them. Just now the NPE DNB board has done a survey and a meeting. The surgical onco exam practical which is going to have should be in a ASCII pattern or a old exam pattern which Sunil explained. Actually, I personally and also all the council members of the surgical onco exam board, we are recommended to go back to the previous format. So this time the practical would be like the old previous format, not the ASCII. So what Professor Sunil Kumar today told is how it would be. So when you have a specimen, you see, identify, start describing it yourself because it is not going to be ASCII. Good. I don't see any questions because it's comprehensively covered. Superb talk. Thank you very much, Sunil. And heartfelt thanks from student, myself, and DNB NB board for covering such a tough topic. It's easy to cover any other topic. This and the instruments, superb, fantastic. Maybe sometime I'll call you for CT X-ray imaging in the practical session when you're convenient. I'll not trouble you immediately. Thank you very much. And over to the NB web coordinator.
My pleasure. Thank you.
Thank you, Dr. Sunil and Dr. so much for your time. With this, we can conclude the session. Thank you, sir.
Thank you. Okay.